Okay, so as people trickle into the room, and again, welcome to everybody who's joining us online. I'd just like to take a couple of moments to welcome you here. Welcome to the School of Policy Studies virtually. My name is Warren Mabey, and I am the director of the school, and I'm delighted that you're able to take some time out of your day to join us. I'm excited to be able to bring us all together on this topic. But before we get into our speaker, I just want to take a moment to acknowledge that I'm sitting here at Queen's University. We are situated on the traditional territories of the Haudenosaunee and the Anishinaabe peoples. It's our privilege to be able to work here and to learn here and to share thoughts here. Because of the virtual nature of this talk, we may be talking to you across many different traditional territories and nations. And I do want to just take a moment to acknowledge where we are, and I hope you'll take a moment to acknowledge where you are and where you're situated. I'm really delighted to welcome you here today, and I actually am going to hand over to our host for this session. Dr. Jane Philpott is the Dean of the Faculty of Health Sciences, and I think she's well known to many of you. Jane, I'm going to hand over to you. Thank you so much.
Thanks very much, Warren, and very happy to be here. Thank you for the invitation. Welcome to everybody. We've got a good crowd showing up for today's Contagion Cultures webinar, which is terrific. Like Warren, I am on campus at Queen's University looking out on beautiful shores of Lake Ontario, and like him, want to acknowledge the traditional territory of the Haudenosaunee, Anishinaabe, the Huron-Wendat, and many other First Nations and Métis peoples. So let me start by sharing a little bit about the background of this series as a little bit of a promo feature on why we're here today. This Contagion Culture series is a series associated with the Faculty of Arts and Science, which is my sister faculty, in collaboration between the School of Policy Studies as well as Languages, Literatures and Cultures, and Queen's Library is also providing substantive support for the series. These talks are on every Tuesday at 4 o'clock Eastern Time, and the series is going to continue at least until the end of the winter term of 2021. This is a series that's been developed to help make sense of the pandemic and take advantage of the expertise and insights of both Queen's faculty members and special guests like you're hearing tonight. So it's a public-facing series that tries to leverage the tools of humanistic analysis and to grapple using those tools with our turbulent times. I wanted to note as well that tonight's event is co-presented by the Institute of Intergovernmental Relations here at Queen's. That's a research institute within the School of Policy Studies, and they were instrumental in getting this particular session off the ground. I hope as you listen to the talk, you'll keep note of some of the questions that you have and use the Q&A feature to type those questions in as we're going along or after the talk, and we'll try to take a good amount of time at the end to answer questions. So now it's my pleasure to introduce you to Dr. Kumanan Wilson, and what a treat it is for all of us to have Dr. Wilson here for this talk. It's entitled The Science, Policy, and Technology of the COVID-19 Vaccine Rollout. Dr. Wilson, I believe, is coming to us today from somewhere in Ottawa, possibly University of Ottawa, maybe home, we'll see. He's a professor at the University of Ottawa, and he is a specialist in general internal medicine. He's also an epidemiologist, and he is the founder and CEO of CANImmunize, which is a science-based tech company. It was a spin out from the Ottawa Hospital, and you'll hear a bit more about that. It allows Canadians to track their vaccinations. The company is just a few years old, but it came into existence at a very critical time as we think about data and how to manage many aspects of the pandemic and track that. I was just recalling with Kumanan that I was proud to be the announcer of funding for CANImmunize in its earlier iteration when I was Minister of Health back in 2017. The government helped the project to get off the ground. You'll see that Dr. Wilson's research focuses on immunization, of course, along with digital health and pandemic preparedness. And he's got some really interesting things to say about social media's impact on vaccine confidence and a whole bunch of other interesting things around health services, data, and vaccine policy. I have had the privilege of being involved and participating with Dr. Wilson at the Ontario Health Data Platform. He's part of our Joint Ministers Roundtable, and we have some great conversations there. So I'm excited about the talk. I know that Dr. Wilson's going to have some terrific insights to share with us about vaccine rollout and all that we're experiencing right now. So with that, I'm passing the floor over to you, and thanks to everybody for being here with us.
Thanks, Jane, and thanks to Queen's for inviting me. I also mentioned I have a long-standing relationship with Queen's as a research associate at the Institute for Intergovernmental Relations. So, fairly ambitious topic to cover today, but obviously very topical. I'm going to begin with, my many conflicts of interest. I want to be transparent about them. So as Dr. Philpott mentioned, I'm the CEO and founder of CANImmunize. I've been a paid consultant to several federal auditor general reports, including the current one that's examining our pandemic response. I'm also a consultant to the World Health Organization of the International Health Regulations, to the Vaccine Task Force. I'm a member of the Independent Data Safety Board for the Medicago COVID-19 vaccine trial, which was just announced for phase 3, is taking place now. So the three broad objectives is to cover the science, policy, and technology of the vaccine rollout, and to try to examine how these all interplay. And hopefully I will have some time to sort of make some suggestions and recommendations of how we can better move forward. So just jump into the science. I like to begin with this slide because I think people don't recognize what an amazing accomplishment this is. This is what we call an immunization moon landing. You know, a year ago, we were obviously didn't know what we were heading into. We were hoping that there'd be some quicker way out of this, maybe some therapeutics, but unfortunately none of that transpired. And then our only hope was a vaccine, but we were beginning from scratch. And it's typically a 10-year process to develop a vaccine. But we have remarkably built a vaccine in a year. And we used the first two that were developed were new technologies, these mRNA vaccines that we never really used in broad population exposures before. And if you can look at from these curves, the top line is what happens when you're not vaccinated, and the bottom line is when you are vaccinated. We don't see graphs like this in medicine very often. These are 95% effective vaccines. This is a remarkable accomplishment in a short period of time, and we're fortunate because honestly, I'm not sure what we would have done if these vaccines hadn't shown up. So just to briefly discuss the mRNA technology. So we've been hearing a lot about the AstraZeneca vaccine. That's a DNA vaccine. That's one of the more typical vaccines. The DNA is put into an adenovirus vector, which goes into the cell. The DNA then triggers the development of mRNA, which then creates the proteins that helps train the immune system. The mRNA vaccines skip that process. They simply provide mRNA into the cell. The reason they've been so difficult to develop is the mRNA is not very stable. So they had to figure out a good way to encapsulate it. And they found these sort of fat bubbles, lipid bubbles that can protect the mRNA and allow it to enter into cells and then code for the proteins that end up on the surface of the cell and then train the immune system. In this case, it's the spike protein. Amongst many of the benefits of these mRNA vaccines is they can be rapidly changed. So we're hearing a lot about variants emerge. If for some reason our vaccines don't work against the variants, you can develop new mRNA vaccines much more quickly than some of the older types of vaccines. And this graph shows the many vaccines that are now available. And on the far right, you can see that there are different efficacies against COVID. But I think that the area in yellow shows that all of the vaccines seem to be quite effective against preventing serious disease. There is an important caveat that I do want to discuss on that. So while we do see variable effectiveness against being infected with COVID, fingers crossed, it does look like this does prevent serious disease. This was reported, not a single death from COVID in anyone who got any of these vaccines in a clinical trial. So I think that's very good news. There is an important caveat in that the median length of follow-up at least in the mRNA trials, was about 60 days. And that's sort of what the regulatory bodies require for safety signal monitoring. So that may not be long enough for individuals to get infected and then develop severe disease and then die, but it is a very positive finding so far that we haven't observed any of these deaths, and we're going to have extended follow-up from these trials that'll give us more information. But there are a lot of questions we still don't know, and we're seeing this play out in the public, and it is understandably causing confusion, but this isn't to be unexpected. Again, this is a remarkable accomplishment. It's also an unprecedented event, this vaccines rollout, because there are multiple vaccines. So the one question is 1 versus 2 dose effectiveness, and the spacing between the 2 doses. I'll speak about that in a bit. Geographic transport, what is the cold chain? And that information is changing. It's being reduced down for the Pfizer vaccine. What we're seeing with AstraZeneca right now in Europe does point out, is this a property of the vaccine, or is this specific to a lot or a manufacturing process? And if there is a signal at all. The impact on infectivity and disease spread, that's to be separated from its prevention of illness. And I'll talk about that briefly. What is the herd immunity threshold? And what is the importance of shield immunity or shielding the vulnerable? So this was a couple of Canadian researchers published this letter in the New England Journal suggesting that the Pfizer vaccine data had been misinterpreted. If you look at the top 2 lines, if you look after dose 1 and beginning 7 days after dose 1, the vaccine efficacy doesn't look that great, and that's what they reported. But the reality is we wouldn't expect good vaccine efficacy in those first 2 weeks because the antibody response doesn't really kick in until about 14 days, which is what they tell you, that you're not really protected until about 10 to 14 days after the vaccine. When we look at that time period, we start to see much greater effectiveness. And it was this observation that was largely responsible for Canada moving from the normal 3-week interval to maybe 4 months, to the 4-month interval that NACI has recommended, that plus some real world data out of Israel. This was obviously of concern that there was an outbreak of COVID-19 in BC care homes where residents and staff were already vaccinated. Nobody got particularly sick though. And this is to distinguish 2 types of immunity. There's sterilizing immunity and there's protective immunity. Sterilizing immunity eliminates the virus and it protects against infectivity. So the smallpox vaccine was a good example of a vaccine that has sterilizing immunity. Other vaccines, like the pertussis vaccine, protect against severe illness, but you can still harbor the virus and potentially transmit it. The reality is most vaccines are somewhere in between. They may not fully sterilize you, but they do reduce your viral load and reduce your infectivity. We're not sure what the situation is with these COVID-19 vaccines, but it's going to be very important because the degree of infectivity you have will affect a lot of our policies, for example, those that are now emerging around immunization passports. A bit about vaccine epidemiology. So typically the vaccine coverage for herd immunity is captured by this formula. It's not that complicated. It looks as 1 minus 1 over the reproductive number divided by the vaccine effectiveness. So if the vaccine effectiveness is 60%, the original reproductive number for SARS-CoV-2 was 2.2. They think the variance may be up around 3, but if the vaccine effectiveness is 60%, then 91% need to be vaccinated. If the vaccine effectiveness is 90%, then 61% need to be vaccinated. So you can see that the vaccine effectiveness, and that effectiveness would have to be on infectivity, could really impact the type of policies we need. If we're only getting around 60% reduction in infectivity, we may need stronger policies to encourage vaccination. If it's around 90%, a voluntary program would probably work. And again, we're in a real world experiment here, and we're looking at a lot of post-market surveillance data. And here's some important data that's coming forward, that your duration of immunity is largely dependent on your age. So as you can see, as you get up to near 80 years old, after 1 dose, the persistence of antibodies is down to about 35% 21 days after that first dose. So the second dose will bump it back up to 88%. So these policies of 4 months, we may need to readjust them based on age. as we get more of this kind of data coming in. But again, we are constantly learning with this vaccine rollout and trying to figure out what the best policies are to implement. But this speaks to something we refer to as immunosenescence, that as an older individual, their immune system, they're not quite as strong and they don't respond quite as well. So let's just switch gears now and move from the science to the policy issues. So immunization in Canada is a challenge because it's what we refer to as an immunization mosaic. It's shared jurisdiction under the Constitution. The federal government would set the standards for immunization. They regulate the vaccines. Through NACI, they provide overall guidelines for the country. But the provinces are responsible for implementation of the vaccines. But effectively, what we have is each province and territory is its own country when it comes to immunization policy. So we discovered this when we created CANImmunize. We basically had to create a different app for each province. They have different schedules. They have different vaccine information sheets. They have different ways of coding the vaccines. The rules on who can report vaccines to public health vary. Who provide the vaccines vary. So this is what underlies some of the challenges we are having as a country when we're trying to create a national immunization approach, that each province and territory does things its own way. Briefly on the point of mandatory vaccination, this will largely be viewed as an unpalatable option for many people. Again, as I mentioned, it may come down to the property of the vaccine. You can't separate these policy issues from the science. For highly effective vaccines, we may not need it. But let's say we do start to notice that you can be vaccinated in a long-term care home and still be infected. There may then be a requirement to be vaccinated to enter into a long-term care home if you're a healthcare worker or a guest. Where this does get complicated is when it comes to employers. They aren't governed by the charter as governments are, and the discretion to bring in policies to protect their workplace and the other employees may permit certain more coercive policies with respect to vaccination. Ideally, we'll have guidance from government on this, but in the absence of that, I think employers are going to act in their own interest, and there's not going to be a harmonized approach. So I've done a fair bit of work on immunity passports. It's a very controversial topic. I think I mentioned this in the CBC Sports article in April, just innocently, and it's really blown up since then. I think they're coming. So under the International Health Regulation Annex 7, the yellow fever vaccine International Certificate for Prophylaxis and Vaccination governs requirements for entering into certain countries where yellow fever is endemic. There's been discussion of the WHO Smart Certificate Group about including the COVID vaccine in this, and they're working on standards, digital standards for immunity passports. It is quite plausible they'll be brought in for international travel. I think Canada's first major challenge that way is if the US does rapidly vaccinate its population, it might include border standards for vaccination, and we are going to have to figure out how to comply with those. I appreciate there are enormous ethical and legal issues, but I would say the larger issues are scientific and technological. So first of all, what is immunity? That's going to vary from jurisdiction to jurisdiction. We're already seeing different schedules across Canada. Is one dose immunity, or do you need two doses? Are two doses 4 months apart? In Canada, we may say that's sufficient. The US may not find that sufficient. So that we have to figure out how to have a harmonized approach scientifically to immunity. And then there are substantial technological challenges. We need to be capturing the data on individuals when they're vaccinated and have those in immunization information systems in a standardized terminology and accessible to the public, associated with a digital identity ideally, and with something called a verifiable credential, which will then authenticate the record that you know it came from an authentic provider of the record and it's not fraudulent. As mentioned, there are going to be substantial federalism challenges because every province and territory is going to want to do this their own way. In some of our explorations, we're already seeing that. Ultimately, what will happen is, in the absence of action, will result in the private sector filling the void. I know there have been a lot of questions about equity about these, but if we don't do this or don't have a approach, what's going to happen is wealthy people are going to be able to purchase these and have the access and those without resources will not have any proof of vaccination, will be probably prohibited from travel. So here are my suggestions. I think they're going to probably be brought in for international travel soon. That's Europe has sort of mentioned something to this effect. We're going to have to align with a global international standard. These standards could permit interprovincial travel and avoiding the quarantine period. Use cases beyond that will be on a province by province basis. And NACI should provide a standard, at least for Canada, for what constitutes immunity, and work with our international partners on that. And then finally, the technology. So again, as I mentioned, this is a patchwork quilt in Canada. This is our immunization registries. The systems don't speak to each other. The federal government is working on that now, but this isn't going to be an easy problem to solve. As mentioned, each province has its own schedule, its own way of coding vaccines. And this really undermined the national surveillance efforts. Right now, actually, our coverage rates are based on a telephone survey for childhood vaccines. We have no way of rolling up this data from the provinces to the federal level. And these issues, these limitations are really highlighted with this COVID vaccine rollout. As mentioned, there are new technologies, there are cold chain issues. We have multiple vaccines available simultaneously. They're multi-dose with constant changes in the recommendations about the dosing intervals, and they've been rapidly developed and approved. So typically in phase 3 clinical trials, we can detect a 1 in 10,000 adverse event rate. Obviously, with a population exposure, rare events can be important. So in the 1976 swine flu preparations, the swine flu vaccine at the time was found to be safe in the trials, but then had a 1 in 100,000 rate of Guillain-Barré syndrome and had to be pulled. We need to evaluate this in subpopulations, and we make the distinction between efficacies, how it performs in a trial, versus effectiveness, how it performs in the real world. And this is the ultimate goal. We need to have real-time geographic dashboards for coverage, effectiveness, and safety. And this needs to guide our decision-making. So we've all heard about what's going on with AstraZeneca now in Europe. That may be a Europe-specific event. We don't know if there is even a signal there, but we need to be able to conduct our own analyses in Canada. So the H1N1 vaccine had an issue with narcolepsy, probably related to an adjuvant. That was very specific to Europe. It wasn't detected in Canada. So we don't want to pull a vaccine here because we don't have data to demonstrate it's safe and rely on another country's data. We need to be able to conduct our own analyses in Canada. And we need to look at subgroups. So a lot of these subgroups weren't included in the initial trial. I see Moderna is starting to do trials in children now. Pregnancy, immunocompromised children, these are some of the populations we need to look at. Older adults, we need to see how long the immunity lasts, and vulnerable and marginalized populations. As Dr. Philpott mentioned, our project has been on digital immunization records centered on individuals. It's called CANImmunize. It's available on the web and on smartphones. When we developed this about 10 years ago. I think it was the first digital immunization solution ever created for individuals. We sort of know that because Apple contacted us and said, we've been waiting for someone to do this. It seemed like such an obvious thing to do. And so from that, we've sort of taken that initial prototype and built the pan-Canadian solution. It's certified by the WHO Vaccine Safety Net, and Europe Center for Disease Prevention and Control uses it as the model. And very simply, we put the paper immunization records on your phone. And this is now, it started off with Immunize On, it's now CANImmunize, and this is the web platform. And this is sort of a blog we wrote. So while my research career started in federalism and migrated to digital technology, we realized actually digital technology could be a way to overcome some of our federalism challenges, that this is sort of the synaptic medium between the provinces. It's a way to move data from one province to another. The digital solutions can be customized to the region and then repurpose the data as you move to another region. And so that was sort of one of the visions, sort of how we can solve some of the challenges we have jurisdictionally in Canada using these new technologies. And as the COVID pandemic has played out, we started to prepare for what will be the largest mass healthcare intervention of our lifetime. the COVID vaccine rollout. And this involved moving from a simple app to an entire clinic flow solution, which we first tested out during the flu season, and now we're implementing in Nova Scotia and the Yukon. And this involves taking, allowing individuals to book their appointments online, fill out informed consent, and then pre-populating clinic management software so that the vaccines can be provided easily by a doctor's office or pharmacist. And it uses standardized data. These individuals, when the healthcare provider, once they identify which vaccine you've received, that data then provided, pushed to the immunization repository, and a vaccine receipt is provided back to the individual. So this is, again, in Nova Scotia, almost in full use now. Like most jurisdictions, we had our initial challenges with the booking. Who would have thought that was going to be the hardest part of all of this? But I think that's sort of across North America, the booking platforms are struggling with the demand. So this is simply booking your appointment, the consent form. When your booking is completed, you get a QR code. And these digital immunization receipts we're working on, and this could be a mechanism for immunization certification, and they can power this reminders. We're holding off on the reminders now because those recommendations are changing all the time. And this can also be used to power adverse event reporting, citizen-based adverse event reporting, which I believe is likely needed moving forward. This is something we had to develop to make the system work in Canada. So as I mentioned, every province and territory codes their vaccines a different way. So we built, supported by initially the Public Health Agency of Canada and now Canada Health Infoway, the Canadian vaccine catalogs. So this is a terminology translator. So depending on how you refer to the vaccine by a trade name, a disease concept, a GTIN number, it maps it to a SNOMED CT code to create a harmonization of data. And this allows systems to speak to each other. So just check my time. I've got a few minutes left. So I think I can finish with what were the challenges to Canada's response and how can we do things better moving forward? So obviously I'm biased because of my background in federalism, but I really do think the problem in Canada is our federal system of government and how it's been interpreted. And this isn't anything new to Canadians. We've had multiple reports, the Auditor General's reports from 1999 and 2001, the SARS reports, all demonstrating the challenges we have with federalism. Unfortunately, these reports come out and nothing much really happens. I don't believe we have fully implemented multilateral information sharing agreements yet. They're on their way, but again, this was highlighted in 1999. In fact, in 1999, the architecture that Canada developed, which was way ahead of the rest of the world, the National Health Surveillance Infrastructure, included GFIN. So we developed web surveillance for diseases before Google even existed. And yet we didn't have it in place when the pandemic occurred. And our systems really aren't much further ahead or behind in some cases other countries. So I think the root cause is we have challenges with coordination, national standards, and data harmonization. And there are other major gaps in Canadian vaccine policy. I'm happy to see that the announcement of a vaccine injury compensation program, but we were the only G7 country that didn't have one. We need a national registry. We need domestic manufacturing capacity. So this is some of the early work I did for the Institute of Intergovernmental Relations at Queen's. First began by studying the blood system and health surveillance and what are the lessons we could learn from the challenges of federalism posed to both managing our blood system and health surveillance. And the main lesson I learned from that was our blood system reform was very successful. We don't hear much about Canadian blood services and the challenges in the blood system because it works so well. By the way, another conflict of interest, I was a former member of the Scientific Advisory Committee for Canadian Blood Services, but the blood system was similar to what immunization was prior to that. It was a subject of ongoing newspaper articles and controversy. And you want the immunization system to get to where the blood system is, where we don't talk about it at all. And it's just a matter of business. So for the members of the Institute of Intergovernmental Relations here, they'll probably be happy to see this. I'm referring to one of your esteemed colleagues, Tom Korshen. He shared this with me at the beginning of my career, his work on access, which is a model for federalism in Canada based on interprovincial collaboration. So the federal-provincial divide is really hard to overcome, and maybe the better way, sort of a confederal approach. And that's where the provinces work together. And we've already seen a model of that during the pandemic, a very successful model, and that's the Atlantic bubble. The provinces out east work together very successfully and have managed the pandemic better than any other region in the country. Canadian Blood Services is essentially an interprovincial model. The provinces run it. AIMA Quebec is separate in Quebec, but otherwise all the provinces are board members. They fund it, and Canadian Blood Services, though, has to respond to federal regulations. So here's my modest proposal, the creation of Canadian Immunization Services, a separate entity, a not-for-profit crown corporation. It would be regulated by the federal government, but it can exceed federal standards, and that's sort of what we're seeing with Canadian Blood Services now. It's funded by the provinces, who are board members. Provinces can voluntarily join. I think realistically, Quebec will likely not participate, but it will collaborate. And that's not a terrible idea. It allows for something called competitive federalism, so you don't have a group mind think. You can have bulk purchasing of vaccines. That Canadian Blood Services buys blood product on behalf of all the provinces and territories, and it will facilitate sharing of data. It also has other advantages. I think the diffusion of expertise across Canada is probably not optimal for immunization. You can consolidate all of that expertise. We can bring NACI and CERN and all of our leading thinkers in immunization together in this organization. It will be free of federal constraints for hiring. I believe our experts should be paid who are on these panels. This is an incredibly important responsibility they have. We need to pay them what their work requires so that they will be able to fully commit to it, free themselves up from their other duties. We don't want these people to do this, trying to fit this in their other jobs. They can support research, and what Canadian Blood Services did, they actually created a capitalized compensation program for blood injuries, transfusion-related injuries, and we can do the same for vaccine injuries. So just to finish off, the COVID-19 vaccination programs represent our best hope for a return to normal. We've had a history of challenges with immunization programs and surveillance, largely related to our approach to federalism. And new approaches are needed, or we will end up making the same mistakes again. And I end with this quote: the definition of insanity is doing the same thing over and over again, expecting a different result. And unless we do something radically different, I don't believe we will make meaningful changes that'll prepare us for the next pandemic. So thank you. I also wrote a comic book, Immunity Warriors, Invasion of the Alien Zombies. You can check it out at immunitywarriors.ca. Website for CANImmunize, CANImmunize.ca, and you can follow us on Twitter at CANImmunize.
Wow, that was fantastic. Okay, folks, mark the date down. You first heard about the creation of the Canadian Immunization Services here tonight at this talk, and it's going to happen. That's my prediction, with Dr. Kumanan Wilson leading the way. So amazing work. You've just been such a leader in this field. This is incredible. So we want to use our time well. There are already dozens of questions. So I'm going to just fly through them, Kumanan. We've got at least 17 or 20 questions. So I'll go through them in the order that they've arrived. So first of all, are Pfizer, Moderna vaccine-resistant COVID variants emerging?
So according to the WHO, there's broad-based immunity that's provided by these vaccines and a broad antibody response. So they believe you will have protection. But there's always a risk of what we call immune escape, pressuring the virus to move towards variants or mutations that can escape the vaccine. It's something we're going to have to keep a close eye on. But right now, they do believe we're covered. The beauty of those mRNA vaccines is if there's a substantial change, we can reformulate them. I think the South Africa one's the one we have the most concern about.
Thanks. And I'll just, some questions are more technical than others, so some will need maybe a little bit of explanation. The next person asks about whether traitorous autoantibodies are linked to COVID deaths.
So the belief, of why some people are getting particularly ill from COVID is that they call cytokine storm, the overactivation of the immune system. And they're trying to figure out how to modulate that. The one treatment that might work is steroids. So people don't fully obviously understand what's going on with COVID-19 and why some people are having these cytokine storm over responsive immune systems. But that's a good question. It's related to somehow and how our immune system is responding.
Thank you. This one you touched on a little bit, but we'll go through it anyway. How long does an immune response to COVID vaccine persist? And the person asks about antibodies and cellular immunity.
That's a really, these are all great questions. So if we follow the antibody response, which we will, because that's our best way of monitoring the how long an immune response lasts, we will always see a fading away, a rapid fading away of an antibody response after an infection or after a vaccine. It's why your lymph nodes don't remain enlarged forever. So there will be a fading away. What's the minimal level of antibody we need to protect you? We're not sure because you have memory cells. But people are starting to believe that much of the immunity for against SARS-CoV-2 may be actually cell mediated, which is T cell, which we don't really have a good way of measuring at a mass level. We can do some cultures. So we're going to have to keep a close eye on this. This could turn into a seasonal vaccine. We could just have enough genetic drift that it becomes like the flu vaccine, and we need a new vaccine every year.
Thank you. You feel under a lot of pressure here? Coming at you one after another?
These are tough questions.
Okay. The next one is submitted by Nicole, and very tragically, she tells us that her mother died from an autoimmune disease, and she's wondering whether she should get one of the mRNA vaccines.
So I would defer to public health guidance on this. And then it's because it's a little unclear, particularly in immunocompromised people. So from a biological model, if you're immunocompromised, as opposed to autoimmune, but immunocompromised, it shouldn't cause harm. And in fact, you may need to be protected. And so the Transplant Society actually recommends vaccination for transplant recipients. But we really we don't have that data now, and we need to start to look at it and have a better sense. So you'd have to follow the recommendations of public health on this.
Thanks. The next person asks about the RBD mutation at E484 in South Africa and Brazil variants. We've got some informed folks here, and those cause a reduction in antibody potency. Why is the question?
So again, it's a change in the spike protein, presumably, which is the most antigenic part of the virus, which is how it enters into cells. That's what our vaccines are targeted at, and that's what your immune response is targeted at. So that changes those initial antibodies that if you've been previously infected, may not work as well. And they've noticed that in some of the studies where they've used convalescent serum, that they didn't work nearly as well on the new variants, and that's a point of concern. Theoretically, with these vaccines, they're getting a broader antibody response than a natural infection, so it might confer that immunity. But we need to, again, this is why we need this post-market surveillance in the data.
Thank you. Someone asks whether there is a third wave of COVID variant pandemic emerging.
When I looked at the Ottawa data, I think we're in our fourth wave, but theoretically, we're going to have 10 waves, where if you look at the percentage of the population that's been infected, still a large percentage of us are susceptible. So obviously there's a considerable risk of a third wave. We're seeing the reproductive number creep above 1. Hopefully summer will allow us to socially distance more effectively. Hopefully we get enough people vaccinated. I think an important part of all of this is if we can shield the vulnerable, maybe, and we can allow the virus to circulate a bit more amongst the general population. Maybe if they're like a flu or a cold, and as long as we can protect the vulnerable, there probably hasn't been a disease that has had this skew on impact on mortality amongst the older populations.
Thank you. Someone asks, can a common cold ward off COVID infection?
So there are a lot of these studies that are actually being conducted now, funded by the Immunity Task Force. I think I'm involved in some of them, where we're looking to see if your previous antibodies to other cold viruses does confer you with any immunity. It's an interesting idea. Is it maybe why kids are maybe a bit more resistant because they were always getting cold and maybe they have some level of immunity, but we don't know. We're waiting for those studies to be done. There's also, by the way, the possibility of the opposite, disease enhancement. So this was the big fear. Antibody-based disease enhancement, like dengue vaccines, that those that got the vaccine got much worse disease. Fortunately, that has not played out here, but that was the other possibility, an early immune priming from a previous exposure.
Good job. We haven't stumped you yet, Kumanan. They're going to get harder, though. The next person asks, how should we handle immunity passports for people who cannot, for health reasons, receive the COVID vaccine?
So obviously we'll need exemptions. So for air travel, I think it's going to be get a test done or have proof of immunization. So that will be an option. What I try to tell people about immunity passports is they don't need to be perfect. Just like the flu vaccine doesn't need to be perfect. The yellow fever vaccine isn't perfect. If you get about 70% right, you will have a major impact probably on the transmission of this disease. So there will be exceptions, there'll be exemptions, there'll be other mechanisms, but it's better than doing nothing.
Great. Can you clarify what the cold chain issues are? That's coming from Dayan.
So as I mentioned, the mRNA vaccine, the reason we've had trouble making mRNA vaccine in the past is they're very fragile. The big breakthrough is figuring out how to keep that genetic material stable enough to get injected into a cell, and that was the lipid bubble has allowed that. That instability is also why the cold chain is so critical, and I'm not sure why Pfizer required a much colder cold chain than Moderna, but I think they're ramping back the Pfizer cold chain, but it was because this mRNA is not particularly stable.
Thank you. So Hannah is worried about, well, she says that her 86-year-old grandpa is worried about his second Pfizer dose being delayed by several months. And what advice do you have for people who are anxious about this?
So the official answer is we can wait up to 4 months. My thoughts are, I think we need to watch that carefully amongst older population because of that antibody data I shared earlier, that the immunity seems to wane more quickly amongst older populations. And I'm hoping those studies are being conducted.
Great. Okay, the next one's good thing you're a policy geek, because there's a policy question for you. The person says, why isn't it considered monstrous that these vaccines, which were developed using public funds, are strongly patent protected and their manufacture and use is restricted by those patents? This is extortion on pain of death. Who defends the system?
I think that's a complex issue that requires some nuance. The private sector has developed these vaccines because of the profit motive. In many cases, these companies are providing them with marginal profits, but they will make a lot of money. Let's not fool anybody here. It is true that a lot of the initial research was provided by governments to support this. It would be, I don't have the clear answer to this. I don't believe eliminating patents is the answer. You lose motivation to create these, but some kind of moderated patent, but I'm not an expert on this. The one thing I will comment on is in Canada, unfortunately, we at one point created the vaccines that eliminated smallpox from the world and polio from the Western Hemisphere through Connaught Labs. And now we don't have that domestic vaccine manufacturing capacity.
Okay, we'll leave that one there unless anyone asks more about that one. Okay, this person asks, should we be comfortable recommending the AstraZeneca vaccine to people over 65 if the clinical trials didn't specifically assess efficacy or effectiveness, safety for this population? I know other countries are going forth with vaccinating older populations. How do we know whether this data, which is not being collected in clinical trials, is reliable?
So there's been a lot of confusion over the over 65 issue. and it's causing some confusion here because NACI just changed its recommendation. I think what they're seeing is it may not prevent illness, but it prevents serious illness. It may not prevent infection, but it prevents serious illness. So I think that's sort of guiding some of the changes in policy that, we need to get people vaccinated. We need to protect them from becoming ill, going to hospitals, or unfortunately dying. And this, it looks like it's accomplishing that objective.
Okay. How efficacious is the Sputnik 5 vaccine?
That I'm not sure, but I do see that countries in Eastern Europe are increasingly using it. I think we should keep an open mind to all of these vaccines to see. They're all going to be likely efficacious in different ways. We may find a vaccine may not be super efficacious, but may have longer lasting immunity. It may be, some may have more sterilizing immunity. So, I think we just have to keep an open mind on all of these vaccines and sort of see what happens in the real world.
Okay, great. So this person asks, Drisha asks, how long will it take to mandate vaccination? And shouldn't enough time be given to assess side effects before mandating a vaccine?
Yeah, so that's a great question. I think for certain populations, for example, long-term care, where we've just seen the horrors that have happened from this disease, the balance of risk is erring on the side of being overly aggressive on immunization policies. As we go beyond that to lower risk populations, I think we have to be more and more careful about how safe and effective this is. So if employers bring this in for healthier populations, I think the burden of proof is going to increasingly be on them to demonstrate that the vaccine is clearly safe and effective before they can mandate it. That being said, our regulators have approved these vaccines.
Thanks. Okay, so the next question from Stephen refers back to the Sinclair lecture we had a few weeks ago. We get great speakers. We had Dr. Bonnie Henry here giving the Sinclair lecture this year, and she was asked about the 2 doses of vaccines that are normally done a few months apart. I think that's sort of referring to vaccines in general being months apart, and the 21 to 28 day recommendation for COVID vaccines is really the anomaly that has been done as a hedge in case the first vaccine didn't provide much protection. That idea has not been well communicated, which seems like a missed opportunity. What other key messages should be emphasized to combat vaccine confusion and hesitancy? So maybe even just focus on the latter part of this. A bit of a long.
I'm going to separate those two. Vaccine confusion is going to happen. And we just have to understand this is a novel situation we're in. Recommendations are going to change. It's going to be really important for our public health officials to clearly communicate that, but it's understandable if the public's confused. I get confused at times. You're going to see sudden changes in policy. I think that 4-month gap is going to change. It's going to apply to younger people, but not to older people. I think that's going to be a change in policy we're going to see down the road. Vaccine hesitancy. I think we've actually done a great job of managing that compared to in the past. We're not attacking the anti-vaccine or the vaccine hesitant. I don't think that's helped. I think there's such huge demand for these vaccines that you're just getting the uptake. I think it depends on what that herd immunity threshold is. If we need to get up to 90%, we're going to have to figure out how to get some of the population more in the margin. But overall, I mean, these are remarkably safe and effective vaccines.
Great. Okay, we're going back to Sputnik. So the Russian Sputnik vaccine, Kim says, seems to have high efficacy, yet Western countries didn't take an interest in it. What are the theories as to why? Were they political, policy, or scientific?
I think it probably related to transparency of the trial procedures. We have our standards in the Western world. We need to have a lot of detail. I'm on this Medicago trial. It's clearly described every step of the way what happens. The data has to be reported, being on the Data Safety Board. I'm not certain, and I can't speak either way if those trials are being conducted to a similar degree of rigor. I believe they released those vaccines even before they'd finished phase 3. I think it was in China as well. They were administering to the army. I thought that was an interesting idea. I'm of mixed opinion if that was a terrible approach or not, given the degree of because given that you finish phase 2, you know the vaccine's safe. So if it's safe, maybe we can start to get it out. But they clearly have a different approach in Russia and China to delivery of vaccine than we do, because they normally would have to have a phase 3 trial done before you could release a vaccine.
You're doing a great job at combining science and policy and politics here. This is good. The next one's a bit along that line too. Is mandatory vaccination unpalatable just because of fear of political extremists? And is this up to politicians to decide?
So I was on the chief science officers panel, and I was debating with the ethicists about some of these issues around immunity passports, and everybody says we have to align with Canadian norms. Problem is, what are Canadian norms? So when I introduced the idea of immunity passports back last fall or last spring, the viewpoint was clearly against it. Now it's shifted substantially. So I think this is just a matter of how we engage in this topic and communicate and be respectful more than anything else. Like if we go in saying you're a horrible person if you don't vaccinate, and we're going to force you to vaccinate, and we don't really care about being transparent about consent or anything, I don't think that's going to go over well. But if we say, to go into a long-term care home, those people are really at risk, they're really vulnerable. Yes, we think they're protected with the vaccine, but we just want to be sure. So until we're sure, this is going to be our policy.
Okay. So the next questioner really likes the idea of the Canadian Immunization Services. So we're getting good endorsement on that. However, what would you anticipate are some of the barriers to its creation?
So the Canadian Blood Services was easier to separate. First of all, it was the Canadian Red Cross. It was sort of a separate entity anyway. And immunization does overlap a lot more with other federal government and provincial government activities. And so pandemic surveillance, pandemic response, et cetera. So I think that that'll be a practical challenge. But then I think politically, there are going to be substantial people opposing this. One of the problems with the Public Health Agency, or the province and territory, didn't want their talent sucked up to the federal level and pulled away from the provinces, which is a legitimate concern. I would hope that interprovincial entity could help alleviate those concerns. How would we do this? Maybe we start out east. Maybe that Atlantic bubble has worked so great. By the way, I'm from New Brunswick, so I'm biased on this. And maybe we start to create a interprovincial collaboration there, and then have members join. We got to do something differently, though. The old way's not working.
Okay, so the next person's on a similar theme, wondering whether discussion around Canada Health transfers could impact the creation of a Canadian Immunization Service.
So actually in my work for Queen's, one of the challenges, this is a little tangent, I apologize, to the system of federalism was this issue of unfunded mandates. The federal government can bring in standards, and the provinces have to pay for them through Canadian Blood Services. So for the variant Creutzfeldt-Jakob disease, when they brought in a policy to ban blood donation, the provinces picked up the tab, and they have no say into what the federal government does. So the provinces were starting to complain about this, that the federal government is just issuing standards and they have to keep paying the cost. So that's something we just started to be cognizant of. Maybe there has to be a transfer of funds at the federal level to support it. But overall, the way that was solved is Canadian Blood Services just started making the standards. They had all the expertise. They had the federal government creates that floor that you can't go below, but often Canadian Blood Services exceeded that because they are the most knowledgeable people in the country on this. But that is a legitimate concern, that if the provinces aren't provided with the funds and the federal government creates the costs, it does cause conflict.
Okay, sounds good. And of course, the transfer could be used as a carrot or a stick, but
yeah. So just on there, the immunization trust was the mechanism the federal government used. This is when they had surpluses to harmonize their immunization schedules across the country. It created a trust and created national guidelines for HPV and other vaccines, and that started to create some harmonization by providing funding for it.
That's great. Okay, on to a science question. If one is vaccinated with AstraZeneca and receives a second dose, will there be any ability to get the mRNA vaccine in the future?
So presumably once you're vaccinated, you're vaccinated unless it's the next year, and then we're talking about seasonal vaccination. But something starting to emerge in the science about mixing and matching these vaccines and creating a better immune response, and like having the second dose being a nucleic acid vaccine, or after the first dose being a non-nucleic acid vaccine. So that they think they can actually augment your response by mixing and matching, but don't do this. This is just something that they're exploring. It just shows you the complexity of the science.
Great. We're not going to actually get through all of these, but I'll try and do a couple more. Someone says that most people express a preference for receiving the AstraZeneca, but they haven't told me why. Do you have any opinion?
My sense is that people are just keen to get a vaccine. From how our booking site collapsed in right away, along with every booking site. By the way, it's up and working great now. I think the AstraZeneca is broadly available. It's a more typical vaccine. It's a DNA vaccine. It's in broad use. I think that does give people some level of comfort. Some people do have some anxieties about the mRNA vaccines because they are new technologies.
Okay. You know what? We've still got a few questions left, but I know Warren wants a couple minutes at the end to say a thank you to you. So I'm going to leave it at that. You have been a trooper and just kept going with all of those questions. That was fantastic and a great talk and super inspiring. Thanks for everything that you're doing, Kumanan. We really owe a debt to you for your contributions to health policy and this great work. So it's been a pleasure to be with you, and I'll pass it over to Warren.
Thank you so much. And thank you, Dr. Wilson, for the time you took today and your presentation. Huge amount of interest, as you can see, tremendous questions from all of you online. So thanks to everybody who took part. And thanks to Dean Philpott for taking time out of her day to moderate this session and to run it so well. Just a couple of things before I let everybody go. I'll remind you all that on Friday at noon, we have a policy talks session. Critical events and ethno-cultural minorities' sense of belonging, exploring the impact of the Charter of Quebec Values and Bill 21. That's with Luc Turgeon of Ottawa, University of Ottawa, and Antoine Bilodeau of Concordia University. And next Tuesday at 4 p.m., we have a Contagion Cultures session. Next week, we have Professors Audrey Kobayashi and Jeff Masuda. And they're going to be talking about neoliberal fault lines and the third sector COVID-19 response in Vancouver single-room occupancy hotels. So fantastic talks coming up. I do hope that people join in, and I wish you all a happy and healthy afternoon, and I hope you get to enjoy some good weather. Thanks so much.
Thanks, everyone.
Bye now.